be talking about biomarkers in heart failure. And I'm going to emphasize on biomarkers per se, and we'll also talk about how these biomarkers help in prognostication of heart failure. So I'm going to get started right away. So, okay. So just a brief overview on heart failure. It's a very complex disease, and it carries a significant amount of mortality and morbidity. 2 to 70% of mortality, patients in hospital, 17 to 45% mortality within 1 year of admission. And the thing about heart failure is that it's not only limited to heart per se, it's a multisystemic disorder, and it involves activation of renin-angiotensin system, which causes salt and water retention. And it also activates the neurohormonal cascade of pathways, which causes inflammation, myocardial stretching, matrix remodeling, myocyte injury, which in turn leads to progression of heart failure, multi-organ damage, and so on and so forth, leading to poor outcomes, and just presents a lot of challenges in managing of these patients as they worsen their heart failure cascade. So hold on. So in this day and age, biomarkers are important in not only establishing a diagnosis of heart failure, but also in prognosis of heart failure, as heart failure may present with very non-specific symptoms in some patients, and especially in some patients who we don't know. Many of these patients are smokers, they have chronic lung problems. So when they present with shortness of breath, and especially some of these patients don't have a lot of peripheral edema or JVD. So though in those patients, it becomes very challenging where their shortness of breath is coming from heart or from lungs. So that causes delay in accurate diagnosis and treatment that may lead to worse clinical outcomes, increased healthcare costs. And there are clinical and imaging tools available like chest X-ray, ECG, but again, they may fail to detect early and subclinical states of heart failure. And that's where biomarkers are important. What are biomarkers? Basically, they are enzymes, hormones, or biological substances that are markers of cardiac stress and malfunction. And these are collectively referred to as biomarkers, and they are valuable in providing additional information that is not available from careful clinical assessment, and imaging and lab data. So biomarkers, they help in aiding diagnosis. They understand the pathological process. They could help us determine the level of severity of heart failure, and they also help us in guiding treatment. So the most common biomarkers that are used nowadays are BNP and the N-terminal prohormone form of BNP called NT-proBNP, as well as cardiac troponin. And they are currently included in guidelines for heart failure diagnosis as well as treatment, as per the recommendations of European Society of Cardiology, American Heart Association, as well as American Heart Failure Society. There are other biomarkers which are in stages of study, like soluble ST2 receptor, which is a marker of inflammation. Then there is a growth differentiating factor 15, cardiac remodeling factor called galactane-3. And these are the biomarkers that we are going to learn about a little bit of each of them as we navigate through this talk. So this is just a cartoon which shows the process of how biomarkers are being released in circulation. And as you can see that there is cardiomyocyte damage and there is restructuring that leads to active and passive release of cardiomyocyte specific biomarkers. And then there are biomarkers which are specific for inflammation, which are specific for ventricular stretching and fibrosis, so there are various stages of heart failure that can lead to release of different biomarkers that can help in understanding of the treatment and where in the sequence of pathological events the patient is. So this is a slide that shows various biomarkers and their importance in terms of prognostication and diagnostic usefulness, their organ or cell of origin, mode of release, as well as their half-life. The most common biomarker which we are going to touch upon in subsequent slides is NT-proBNP, which, as you can see, helps in both prognostic as well as diagnostic information released from cardiac ventricles actively upon cardiomyocyte injury, with the long pro half-life 120 minutes, which makes it useful in detection in the bloodstream. Then there is mid-range pro-NP, which is used in prognostication as well as diagnostic purposes, released from cardiac ventricles. Troponin INT, diagnostic and maybe prognostic, released from cardiac thin filament. Then there is cardiac myosin BPC, which is released from cardiac thick filament. Then there is, again, there are many abbreviations that we are going to talk about. So again, HFA-BP, again, high fatty acid molecule, which helps in prognostication, galectin-3, growth differentiating factor 15, and SST2. Again, the biomarkers which are lower down the list, they are in evolving stages of study. So as of now, they are useful in diagnostic values, but more work is being done on them as we speak. So talking about biomarkers, natriuretic peptides, the most, I would say, extensively studied biomarker. It regulates volume and pressure overload. These are produced as pre-prohormones, which are cleaved to form prohormones and later the final hormones. There are various forms of natriuretic peptides, atrial ANP. Then there is brain natriuretic peptide, also known as BNP. And then there is a C-type natriuretic peptide called CNP. All of them have their own receptors, A, B, or C, which are guanylyl cyclase receptors. And both ANP and BNP, they have similar physiological roles. They act by binding to their receptors, causing diuresis, natriuresis, vasodilatation in an attempt to reduce cardiac preload. In addition, they also inhibit the renin-angiotensin aldosterone system. They inhibit aldosterone synthesis, renin secretion, which in turn reduces the cardiac afterload. BNP is coded by NPP gene. And again, it's secreted in response to ventricular stretching. And as you could see, the BNP level in healthy individuals are 3.5 picogram per ml in plasma, which could increase up to 100-fold times in heart failure patients. BNP has a short half-life of 20 minutes. So that's why we use NT-proBNP, which is a prohormone form of BNP, which has longer circulation half-life of up to 120 minutes. And that's what is more commonly used for heart failure purposes. They are reliable gold standard diagnostic biomarkers in heart failure. They're well understood and they have cardiac specific biological function, and they have been studied in various trials. Some of them I'm going to mention briefly. There have been quite a few of trials, but it's hard to mention all of them within the scope of this presentation. So some of the important trials that have studied these biomarkers: Paradigm heart failure trial that came out in 2016, and that quantified NT-proBNP levels in around 2,100 patients, and that showed reduction in NT-proBNP levels had lower rate of heart failure, hospitalization, and cardiovascular death. Then there's a study came out in 2020 called Transition Study, which again showed that reduced NT-proBNP level at 4 weeks was indicative of lower risk of heart failure, rehospitalization, and CV death. So I think rehospitalization is very important as well, and the levels of proBNP has shown that the lower the levels, if you reduce the levels of proBNP, percentage reduction in levels of proBNP have shown to reduce the hospitalizations or recurrence of hospitalizations as well. Then there is a mid-region of pro-ANP called MR-pro-ANP, which is secreted in response to atrial volume stretch receptors, and they act similar to BNP. They have their own receptor called NPRA, and it also results in decreasing extracellular fluid volume and blood volume. Normal levels are around 20 picogram per ml, and it rises to 10 to 100 times in heart failure patients. And again, for similar reason, as we mentioned, NT-proBNP, it's hard to measure a bioactive form of ANP because of its short half-life. So we measure the mid-region of pro-ANP, which is less susceptible to degradation, and hence that is used in clinical assessment. So again, the trial that studied the ANP, the mid-region ANP, was the Molitor trial. And it showed that MR-pro-ANP predicted the reduced physical and mental quality of life as compared to pro-BNP, which was predictive of physical quality of life. So again, pro-ANP also has usefulness in predicting the quality of life. So we'll move on to the next marker, which is studied cardiac troponin. Again, time and tested cardiac troponin plays a key role in cardiac and skeletal muscle contraction, and it causes, it represents a picture of myocardial damage and not heart failure itself. And they are known as cardiac injury biomarkers. And guidelines recommend measuring a cardiac troponin along with natriuretic peptides at the time of hospitalization. It could serve a few different purposes. First, the level of myocardial injury, or identified acute coronary syndrome as underlying cause of heart failure in patients. So a couple of places where cardiac troponin could be useful in heart failure patients. Again, where many studies have established the usefulness of cardiac troponin in heart failure patients. Some of them are ASCENT heart failure studied, which showed that elevated levels of cardiac troponin I was seen in 50% of decompensated heart failure patients and helped in predicting in-hospital patient outcome with a p-value which was very significant. Corona trial was studied in a subgroup of elderly patients, in ischemic cardiomyopathy, and cardiac troponin provided a strong and independent prognosis of cardiovascular death, stroke, heart failure, hospitalization in older patients. And then there's another study called RELAX AHF study, which showed association between serial measurements of cardiac troponin measurements and outcomes. And that was also a very favorable study showing the importance of cardiac troponin in these patients. The other biomarker is cardiac myosin binding protein C, which is encoded by MYBPC3 gene. It causes important role in sarcomere structure and maintenance and regulation of muscle contraction through modulation of actin-myosin bridges. It's cardiac specific and highly sensitive characteristic, making circulating cardiomyosin an ideal target to be evaluated as biomarker for subclinical cardiovascular states and a candidate biomarker for heart failure prognostication. Another evolving biomarker is heart type fatty acid binding protein, which is a biomarker for cardiac cell death and may provide a different quality of information on cardiac pathology in terms of early detection of subclinical disease, because it has a cytosolic location that could also help in providing additional information about heart failure. Galectin-3 is a member of galectin family, and It is also being studied. However, the tissue of origin remains a matter of debate, and because of lack of cardiac specificity, it has not shown as of now to be of much limited, or it has limited prognostic value as compared to other biomarkers. Growth differentiating factor 15, also known as macrophage inhibitory cytokinin 1. It's a member of transforming growth factor family. It is released in patients with heart failure. Again, it lacks very tissue specificity, and studies are still ongoing to detect the specific tissue of origin. Then I'm going to talk very briefly upon genetic biomarkers. So the ones that we talked about were the protein biomarkers. These are the genetic biomarkers. And again, this is also an evolving field. Genetic analysis, development of gene-based biomarkers. The samples are sequenced and analyzed by various techniques. Again, these are big acronyms, which even when I was presenting this, I got to know some of them. GWAS, TWAS, these are called genome-wide association studies, transcriptome-wide association studies, weighted gene co-expression network analysis. So samples are sequenced and processed by these studies, and the results are then processed using bioinformatics, providing information on a single nucleopeptide or gene loci associated with heart failure. These are time-consuming, complex, and actually very expensive for routine clinical use as compared to other protein-based biomarkers. But eventually, I think these carry a very potential. They may provide a unique opportunity for treatment and early risk prediction. Patients who have certain genes could be more predisposed to heart failure, and early intervention could be performed eventually when we have more research and when it becomes less expensive for use in day-to-day use. Then we have transcriptomics-based biomarkers, which are called non-coding RNAs. And there are some non-coding regions in genome which have been widely implicated in biology. Some subcategories of non-coding RNAs have been described. Some of them have been studied more than the others, especially microRNAs. They have been studied extensively. Other classes have been identified as non-coding RNAs called INC RNAs and circular RNAs. And some of them have been studied in context of cardiovascular disease and heart failure, which again, is something which is an evolving field, and they can be additive to protein biomarkers in the future. So again, there are, as I mentioned, there are protein biomarkers, there are genetic biomarkers, there are non-coding biomarkers. And the protein biomarkers are the most commonly used because of their pathophysiological reliability, stability, accessibility, added value, detectability, diagnostic and prognostic validation, consensual agreement, reference values, comparability. Of course, protein biomarkers have some limitations. Gender specificity might have some limitation, and ethnicity, the levels might be different, and they can be seen in some other conditions, like patients who are obese. Their levels are typically low than those who are not obese. So they have some limitations, but overall, protein biomarkers are gold standard. Genetic and non-coding RNA biomarkers are evolving field, and in the future we may see more use for them as more studies and they are being studied. These are the guidelines for recommendations for use of biomarkers, and as you could see, BNP or NT-proBNP for diagnosis, the level of recommendation, class of recommendation is class 1. Level of evidence is A. Hospital prognosis is again in class 1 recommendation. Prevention is 2A, and it also helps in hospital discharge prognosis and guided therapy in chronic heart failure. For troponin T or I, again, its class of recommendation is 1, which is a very strong recommendation for hospital admission prognosis. And other biomarkers have also made their way in guidelines, although the class of recommendation is not very strong. It's a 2B, so it's not as robust as the others, but it might get there once more studies are done. Then I'm going to touch a little bit on prognostic last few slides on prognostic models of heart failure. There have been a lot of models in recent years for heart failure. The most commonly used till recently was Seattle heart failure model. Then there was MAGIC model, which was meta-analysis global group in chronic heart failure. The limitation in these two models was that it included variables mostly in the clinical setting. These have been used for a long time, and that did not include the recent advancements in heart failure like neprilysin inhibitors, SGLT2 inhibitors. So again, in mostly clinical variables, and these were developed before recent therapies. And these did not incorporate biomarkers who have a strong prognostic values. So those were the limitations on these Seattle heart failure model, as well as the MAGIC model. More recently, there have been other models called Predict Heart Failure 5, Biostar CHF6. They have included the natriuretic peptides, but not the troponin in their models. So again, they have the other limitation in these models are that these models can sometimes include as much as 30 plus variables. That is a limitation on how much variable you can use. It just confuses everybody. More and more variables you use to incorporate a risk model. So the goal for risk model is to incorporate the current data, which includes clinical data, the lab data, biomarkers, as well as reduce lower number of variables as we can, so that it does not become too big and too confusing. So in this context, a study that has just recently come across, it's called Novel Biomarker-Driven Prognostic Models to Predict Morbidity and Mortality in Chronic Heart Failure. This was published in European Heart Journal. And this came up with a model to prognosticate heart failure based on cardiac biomarkers. So initially they used 33 candidate variables were pre-selected, and they used a multi-variable Cox regression model to see which variables could be used to predict the primary composite outcome of heart failure hospitalization or cardiovascular death, all-cause death, and cardiovascular mortality. So around 4,000 patients were followed up for about 16 months. And the study concluded, which I will go over in a table and a graphic form, that NT, proBNP, and high sensitivity cardiac troponin were the dominant predictors of primary outcome. They predicted reduction in primary outcome as well as secondary outcomes. And there are other variables that also showed improvement in primary and secondary outcomes for shorter time since last heart failure hospitalization, longer time since heart failure diagnosis, lower systolic blood pressure, heart failure class, high heart rate, and peripheral edema. And the primary outcome risk discriminated well, with patients in top 10th of risk having event rate more than 9 times than in bottom 10. So patients who were in top 10 percentile were 9 times higher risk for developing primary outcome. And not only this, NT-proBNP and high sensitivity troponin were also dominant predictors of all-cause and cardiovascular mortality. So again, these are the variables that predominantly affected the primary outcome. ProBNP level p-value is extremely strong, less than 0.0001. TNT values, time since most recent heart failure hospitalization, time since heart failure diagnosis, systolic blood pressure, class 3 or 4 heart failure heart rate, which is per 10 beats minutes higher. And higher the heart rate, the poorer the prognosis, peripheral edema, and also randomization to empagliflozin. So, and again, this is again a table of these nine variables that are strong predictors of heart failure prognosis. And then there are 4 variables that predicted all-cause cardiovascular mortality, which included proBNP, troponin, NYHA class, ischemic etiology, and patients in top 10th of risk had event rate more than 9 times than in bottom 10th. So I think, that is almost time for my presentation. So the bottom line from my takeaway is that, in this day and age, cardio biomarkers are important. Of course, no one can, clinical data, lab data, and imaging data, they are very, very useful, but proBNP, cardiac troponin, they are readily available and should be used routinely, not only for diagnosis, but serial measurements in terms of prognostication in conjunction with other clinical variables. They're very useful. So I think that was the last slide, and I would be open